This is Chapter 24, Rehabilitation of Injuries to the Spine. This chapter is about the spine, so we'll discuss cervical, thoracic, and lumbar spine. However, as we know, there is a predominance of lumbar spine injuries in practice, so that is where a majority of the time will be spent. We have already talked about the lower back in Chapter 5 with core stability. You will see that many of those concepts will be used here for low back pain, especially in the early portions of rehab. The anatomy in these two pictures is just a refresher. The picture on your right, especially, should look familiar. Review the anatomical structures of the spine if need be. For the sake of the lumbar spine, I brought back this slide from Chapter 5. We will be concerned with the multifidus and the transverse abdominis when discussing low back pain. This will be the first muscles that you will strengthen during rehab, but if you remember, the point is to only turn them on as opposed to making them really contract. This slide gives some general information regarding low back pain rehab. Note the rules of thumb. Plain and simple, if it makes things worse, don't do it. If it does not make things worse, go ahead. As stated, chase the pain, but don't catch it. The last two main statements give good advice for any rehab, although it does have a little more pertinence in the low back. If patients get pain relief from exercises, they will continue to do them. If they get pain relief from something passive such as cupping, scraping, electrical stimulation, or any other modality, then get exercise to keep the pain away, patients will defer to the passive activity and not do exercises. Remember that. And do you see this in your clinical experience? As the transverse abdominis is important, I also brought back this slide from Chapter 5. If you forgot about the various cues to give the patient for the home base or drawing in maneuver, here they are. These will be valuable in clinical practice, especially if you are a clinician in a general orthopedic practice where many of your patients will have low back pain. Try to commit these to memory. It also helps if you can do them as a clinician. Something that goes along with TA activation is multifidus activation. You'll want to make sure both muscles are firing accordingly without recruiting the bigger global muscles. Palpation by a clinician or by the patient themselves can clue in how well they are doing with that. If this is working well, they should be able to maintain this while progressing through exercises. Until these muscles offer spinal segment control, you will have faulty spinal stability. Make sure the TA and the multifidus are continually assessed through the rehab process. A lateral shift correction is manually adjusting the hips to promote proper posture. You can read the indications and the techniques for a clinician and self-correction are in the text on the noted pages. This slide discusses two primary schools of thought for spinal rehabilitation. One, you have extension exercises, which are sometimes called McKenzie exercises. Two, you have flexion exercises, which may be collectively known as Williams exercises. Note the indications for each align with the rules of thumb from a few slides ago. To get an idea of what is designated flexion versus extension, you can look at the textbook on the pages listed. You probably know most of these, but do not realize that they are spinal exercises. This slide talks about the various manual therapy options for low back pain. Joint mobilizations are done the same way as we talked about. Indications and contraindications do not change. There are many self-mobilization techniques in the book on the page numbers listed. One thing of note, there is a standing T-spine mobility exercise, but they do not have the quadruped T-spine mobilization listed. That is something we see being used in the AT facility regularly. The other manual therapy listed is spinal manipulation. Personally, I have always been told that manipulations are beyond an AT scope of practice. However, that may be antiquated thinking. What I take from that portion is that as long as you are doing what you should, manipulations can happen regardless. As I say, there probably is not one person watching this who can say they have not tried doing something like what pictures on 823, 840, and 841 depict. Also note the last point in the right column. As Brian Kelly said, noises do not have to mean that manipulation occurred, and an absence of which does not mean manipulation did not occur. I told you this slide would be on every lecture. And here are a few other tidbits about your standard NSLBP. For rehab purposes, I want you to answer the question on the third line. Is the lower back actually to blame for many cases of LBP? If not, where do you see some issues arising that create a low back pain situation? And, we discussed this a few slides ago, but what will you be doing with someone when the acute phase is on the way out and phase 2 is beginning? These are some of the specific injuries that you'll see in the lumbar spine. With myofascial pain and trigger point release, hypertoned areas of muscle can be found in any situation, and we have a multitude of ways to treat them. Relieving some of that tightness and contraction can go a long way to resolve lingering NSLBP symptoms. The two spondies are there. Do you remember which one is collared Scotty dog and which one is decapitated Scotty dog? You are still capable of participation with the collared Scotty dog, but you should hopefully have a very good spinal segment control when you do. Disc-related pain and SI joint dysfunction are both mentioned in detail with the rehabilitation plan. Do not be afraid to look at those protocols prior to the next class so you can get an idea of how to progress with the situations we talk about in class. The last slide discussed a few somewhat common thoracic and cervical spine conditions. Schuermann's kyphosis can be found in adolescents, and the common treatment is the Milwaukee brace. Check out the video to see what they look like. If you remember, Schuermann's disease leads to increased kyphotic curve because the T-spine vertebrae bodies begin to wear away and create a greater wedge. With kyphosis being in the sagittal plane, scoliosis is a variation in the spine in the frontal plane. A Milwaukee brace could be used for this also. However, most non-severe cases of both of these can be treated conservatively. On the right, we have a few C-spine conditions. The first bullet is a longer term for what we know as wry neck or torticollis. As you can speak if you have had this, once the pain subsides, things tend to improve quickly. It is just a matter of easing the symptoms. Cervical sprains and strains manifest in a similar fashion upon evaluation, so differentiating between the two is not a huge concern. As long as you continue to follow appropriate protocol and not jeopardize the patient's spinal health, you are fine.